The book, The Treatment of Certain Heart Conditions by Homeopathy, Douglas Morris Borland. Section Acute Heart Failure. Antimony tart. The antimony tart patients present a somewhat similar picture, but there are clear points of difference. In antimony tart, there is more a definite tendency towards cyanosis than in arsenic. One never sees an antimony tart patient without very definite signs of cyanosis. This may involve the whole extremities or may be confined to the finger and toenails. One never sees the same kind of mental anxiety in antimony tart. The patients are more down and out, much more hopeless and more depressed. They are never quite so restless and never quite so pale. Again, there is none of the thirst one meets within arsenic. In fact, anything to drink seems to increase the patient's distress. Another contrast is that the antimony tart patient is very much aggravated by heat and especially by any stuffiness in the atmosphere. There is one point worth noting here as a contrast between antimony tart and Carbo. Antimony tart patients do not like a stream of air circulating around them. They want the room fresh, but they like it still. In most of these antimony tart patients, there is a very early tendency to edema of the lower extremities. Another point which helps you in your antimony tart selection is that practically all these patients have a very thickly coated tongue, a white coat with a rather sticky, uncomfortable mouth. They have a feeling of fullness in the chest rather than the feeling of acute pressure found in arsenic, and one usually finds pretty generalized diffused rales in the lower part of the chest on both sides. In contrast to arsenic, if one has a case of this type, it is the kind of collapse one meets with after a pneumonic crisis. If the patient responds to antimony tart, it will carry him through. One does not have to be on the jump to find the follow-up drug as one has to be in the arsenic case. Carbo. Carbo presents the classical picture of patients with all the symptoms of collapse. They have the cold sweaty skin. They are mentally dull, rather foggy in their outlook, have not a very clear idea of where they are or what is going to happen to them. They have the most intense air hunger, and in spite of their cold, clammy extremities, they want the air blowing on them. They cannot bear to have the bedclothes around their necks, and they do definitely benefit from the administration of oxygen. They are very much paler than the antimony tart patients. The lips tend to be pale rather than cyanotic, and there is none of the underlying blueness one associates with antimony tart. The next point is that they always have a feeling of horrible distension. It is very often complained of, not so much in the chest as in the upper abdomen, and their cardiac distress is always associated with a good deal of flatulence. Like the antimony tart patients, any attempt to eat or drink tends very much to increase their distress, and they have none of the arsenic thirst. Another apparent contradiction you come across in Carbo is that, in spite of their desire to be uncovered and the intolerance of blankets around the upper part of the neck or chest, these Carbo patients complain of ice cold extremities. They feel as if the legs are just lumps of lead and they cannot get them warm at all. I think in Carbo one has to be careful as to how long one is to keep up the administration once the patient is responding, sweating less, the surface becoming warmer and the distress less acute. It is wise then to hunt round for a second drug in case of need, because some Carbo patients do relapse, although many of them make quite a straight recovery on Carbo. One does have to be careful. If one finds a patient who has responded up to a point of Carbo, it does not follow that a higher potency of Carbo is going to carry on the good work. As a rule, it does not, and it is much better to hunt round for a fresh drug to keep up the reaction. Often, when the patient has responded only up to a point to the administration of Carbo-Veg, the follow-up drug will be found to be sulfur, but kali carb should always be considered. Oxalic acid. Oxalic acid has one or two very outstanding symptoms which are often met with in a case of collapse, which are a great help in the selection of the drug. First, the patient always complains of feeling of most intense exhaustion. Associated with that exhaustion, there is usually a sense of numbness. The patients very often tell you their legs and feet feel numb and paralyzed, and often they say they don't feel as if they had any legs at all. The skin surface is just about as cold and clammy as it is in Carbo-Veg, but there is a peculiar motile cyanosis in oxalic acid which one does not get in the other drugs. The fingertips and fingernails and toenails will be definitely cyanotic, but in addition to that, there is a peculiar mottled appearance of the hands and feet which is quite distinctive of oxalic acid. There is somewhat similar mottled cyanotic appearance in the face, very often over the malar bones. These patients, in contrast to the arsenic patient, want to keep absolutely dead still. Movement of any kind vastly increases their distress. In addition to their general distress, most of these oxalic patients complain of peculiar, very definite, sharp precordial pains. The pain is not like the typical anginous pain. It is a sharp pricking sort of pain which usually comes through from the back and may run up the left side of sternum towards the clavicle or down the left side of the sternum into the epigastrium. The most startling cases giving this picture that I have seen have been in the critical stage of influengal pneumonia, where the patient is just spittering out, seemed to have lost all strength, was dead beat, and the heart was just giving out. All the patients of that type that I have seen have had left basal pneumonias. I remember seeing 2 or 3 cases which apparently were doing quite well on natrum sulf and collapsed, and they reacted beautifully to oxalic acid, but one does not get indications for it in chronic cardiac cases as well.